How much lucky can one get? Well, I was extremely lucky with this case. Let's find out. The patient has a deep set eyes. The surgery is being performed under topical anesthesia. The rhexis is done. And time to do emulsification of this case. No hydrodissection, as I typically avoid this in all mature cataracts. So time to emulsify the nucleus. The superficial epinucleus is aspirated. There's a lot of pooling of fluid which is happening. And I'm expecting my assistant to help me out with this. He's just connected to the suction machine and trying to clear off the place. So the plan is to do a trench and then chop. So I'm going to begin my trenching. I'm using continuous torsional energy to do the trenching. I just create a central pit which gives me enough space and allows me access to the central core of the nucleus so that I can bury my phaco tip deep into it and then do my vertical chopping. The settings are changed to the longitudinal mode. The tip is buried into the substance of the nucleus. The vertical chopper goes down vertically, and then there is lateral separation maneuvers. The nucleus is slightly dense. The second chop is being performed, and because of the density of the nucleus, a couple of attempts of lateral separation are necessary to break the posterior plate. The tip is buried again. The vertical chopper goes in to produce the third chop, and we have a free fragment ready. The chopping is continued. Now we have a free fragment which is pulled out of the bag and then is being emulsified. So far so good. Things are looking to be very much under control. The next fragment is held, pulled out of the bag and then emulsified. Things are looking as routine as it could be. So now I'm left with the last three fragments, and two of them are appearing to be having joined at the posterior plate. Nevertheless, the fragments are flipped aside. A gentle lateral separation maneuver ensures that these fragments are freed and each of them is now being emulsified. In the background, I can see the epinucleus is there, and we have a large single last fragment remaining. I thought after just emulsifying this piece, that should be the end of the nucleus management. As the last fragment is tipped out of the bag and then is being emulsified, something catches my attention. An unusually bright red reflex posterior to the nucleus has caught my eye. This I thought is a little bit unusual. Nevertheless, the emulsification is going on pretty well. The followability is excellent, so it looks alright, but this underlying red reflex is something which is bothering me a little bit now. As the last piece is getting emulsified, something is not looking alright. This is not usual. Well, in a few seconds, it becomes very obvious that a large PC tear is staring at me. And at this point, a million questions are bombarding in my head. When did it happen? Why did it happen? How did it happen? Well, at that point, these questions can always wait. The first thing I need to tell myself is that I got a job at my hand and finished this case in the right way. The followability is excellent. It means that the vitreous is still not clogging the phaco tip. So this is an indirect evidence that the vitreous is not way into the antechamber. I can see a small fluffy cortex in the antivitreous. And since the followability is good, I could go ahead, engage these fragments and emulsify them. Before withdrawing, I asked my assistant to get the dispersive OVD ready. This is a combination of chondroitin sulfate and hyaluronate that's being injected through the side port. The irrigation is turned off. The handpiece is out now. As I center my microscope, I can clearly visualize things now. An equator to equator posterior capsular tear is staring at me. The small fluffy cortex has dropped down, and the vitreous seems to be present at the level of the posterior capsular tear. Since the posterior capsular tear edges are not flayed wide open, I suspect that the vitreous prolapse into the antechamber is still not happened. So anyway, let's confirm it by using diluted triamcinolone acetate. So the triamcinolone acetate descends down into the vitreous cavity, but of course there is prolapse of the vitreous, but it is still at the level of the posterior capsular tear. Again, I see a small fragment in the angle towards my left hand side. I'm using viscoelastic to just burp it out. And the other smaller fragment is removed with the help of a forceps. The antivitrectomy is begun, and in just a couple of minutes the vitreous is taken care of. Now, looking at the edge of the posterior capsule gives an indication whether there is a vitreous strand which is traversing towards the incision. Now, because the posterior capsule tear edge in this side is pulling towards the incision, it's very obvious that the vitreous would be there, and in a matter of few minutes, as the prolapsed vitreous is taken care of, you can see the shape of the edge of the posterior capsule tear changes. At this point, the prolapsed vitreous is taken care of. There's no evidence of vitreous. Now is the time to deal with the cortex. And using the same vitrectomy cutter, I'm going to engage the cortex, strip it off, and then aspirate it. The hands are switched and the cortex from the other quadrant is then similarly aspirated with the vitractor. The tiny bit of cortex under the subincisional area is also taken care by the vitractor. Time to implant the lens. Space is created under the iris and above the anticapsule by using sodium hyaluronate 1.4%. Before implanting the lens, I'm enlarging the incision to 3 mm. I'm going to use a multi-piece Acrysoft lens in a Type C cartridge. Now, because the eye will be hypotenuse, it's mandatory for us to enlarge the incision just a little bit so that we can introduce the cartridge much more easily. The haptics are directly landing above the anticapsule, and the second trailing haptic is then dialed into the sulcus. So now we have the multi-piece lens into the sulcus. Before achieving the optic capture, I would want to go ahead and remove some of the OVD which is there behind. In a vitrectomized eye, when we want to go inside, again mind the infusion. See, I'm going in with my cutter alone. There is no infusion now. After a couple of seconds, the infusion is being introduced into the eye, again with the lowest possible bottle height. Mind you, when in a vitrectomized eye with an open posterior capsule, if you go in with a very high infusion, there are distinct possibilities of the lens itself dropping down in the vitreous cavity because of the raised infusion. So always begin with the low infusion and gradually increase the infusion as the OVD gets aspirated out. So I prefer to always go ahead and remove the OVD which is gone behind the lens and then in front of the lens, and once the eye is clear of the OVD, now is the time to do the optic capture. The irrigation still continues to be in the left hand, and I'm going to push the optic behind the anticapsule. As we can see, the capsule rexis is slightly bigger than what is the most ideal one for achieving optic capture in these situations. Nevertheless, something is still better than nothing. So one side of the optic is totally covered by the rexis margin. The other edge of the optic is not completely covered by the rexis margin, but it's fine. Something is still better than nothing, and this ensures better centration and stability of the lens over the period of time. With the irrigation still inside, I'm injecting diluted triamcinolone acetate one last time to confirm the absence of any vitreous fiber peeking around, and thankfully there is none. The side ports are hydrated, intracameral antibiotics are placed, and that's it, the case is done. So these are the first day post-op pictures, and the patient was doing well and continues to do well after a month and a half. So now back to the million-dollar question. When did the PC tear happen? I watched the video at least 6 to 8 times for me to understand when it happened, but unfortunately I just couldn't figure out when. So let me rewind it step by step. The first time I noticed actually when half of the last piece was emulsified. Actually, if I rewind, I can see at the beginning of the emulsification of the last piece itself, the enhanced red glow is visible. Actually, this part of the red glow enhanced in the editing software, and then now it is very much visible, this line, suggesting that the PC tear was already existing now. So if we go behind still, the first evidence which I could gather from after viewing it multiple times was at this stage, where I can see 2 small fluffy cortex in the vitreous. Actually, when I was doing surgery, this was not visible at all because your focus is always on your phaco-tip and the lens, but back behind this epinucleus, there are these 2 fluffy cortex which were there. That suggests that the PC tear was there from quite some time. I don't know. So I was unaware and the nucleus was rotated. The chopping maneuver was usual, but I can't thank my stars enough. With such a large PC tear, the nucleus still didn't drop, not even a fragment. So as the saying goes, it is sometimes better to be lucky than good. So on a serious note, why did the nucleus didn't drop in this case? Well, the speed at which the nucleus descends down into the vitreous cavity primarily depends upon the consistency of the vitreous. A gel-like vitreous prevents the sudden dropping down of the nucleus, whereas a more degenerative or a syncytic fluid-like vitreous, the nucleus can just drop down in a jiffy. Well, I was grateful that the vitreous did support me in this case, and thankfully there is no nucleus drop. So back to the question of why did the PC tear happen, I am not sure. Possibility of this being a postpolar cataract, the other eye had pseudophakic and there's no evidence of PC tear in that eye. There's no evidence of any intravitreal injection being given into this eye, so I'm not so sure. But looking at the configuration of the posterior capsule tear, equator to equator, a linear split, it looks like possibly a weak pre-existing posterior capsule secondary to postpolar or something else. I don't know. So that was it. Thank you for watching and hope you found this helpful.